All right. Good evening, everyone. Oh, it got real quiet. Bruce, we're good? All right. Good evening, everyone. Everyone here in person and online. My name is Dr. Mark. I gotta check what my name is, you guys. My name is Dr. Margaret Tando, and I'm the Associate Dean for Diversity, Equity, and Inclusion here at the Larner College of Medicine. It is my great privilege to welcome you all to the 11th annual Reverend Dr. Martin Luther King Health Equity Lecture. Before we get started, I would like to say that it is with deep sadness that we acknowledge the passing of Dr. King's youngest son, Dexter Scott King. Earlier this week, after a long battle with prostate cancer, he died. His sister, the Reverend Dr. Bernice King said, "I understand from his wife when he passed, he had a smile on his face." And I think that was my parents saying, "Welcome home, son. You fought a good fight." Dexter King and his three siblings faced the unique challenge of growing up without their father while carrying on his legacy. We send our heartfelt condolences to the King family. The Martin Luther King Health Equity Lecture was created in 2014 to inspire our community to engage in dialogue, community engagement, and civic education around topics of inequity and inequality in medicine and their relationship to the vast health disparities we see in our society. Thanks to the generous support of our dean of the College of Medicine and our Larner alumni, the lecture has grown tremendously over the past decade, and we are pleased that members of both our university and local communities participate each year. Tonight, we join here in the room as well as people virtually. Am I supposed to get a number? Over 50 people online. Each year, we have short speakers that include scholars and thought leaders whose leadership, scholarship, and perspective and viewpoints enhance our understanding and appreciation for inclusive excellence. Of all the forms of inequality, injustice in health is the most shocking and inhumane. These words spoken by Reverend Dr. Martin Luther King in 1966 during a speech to the Medical Committee for Human Rights still ring as true today as they did back then. As we celebrate the life and work of Dr. King, we can also reflect on how his commitment to ending injustice can also apply to the work of eliminating health disparities within populations here in our communities and around the world. I would now like to introduce Dr. Krista Zala, who she is the Senior Associate Dean for Medical Education, who will make some remarks on behalf of the Larner College of Medicine. I would like to say that our Dean Page sends his best regards and his regrets that he cannot be here tonight. So, Dr. Zala, thank you very much.
Thank you so much, Dean Tando. Good evening, everyone. Thank you so much for being here. On behalf of Dean Page and the Larner College of Medicine, I would like to welcome our faculty, staff, students, and guests, both in person and those joining us remotely, to the Larner College of Medicine's annual Martin Luther King Health Equity presentation. As Dean Tando mentioned, Dean Page is unable to be here this evening due to a previously scheduled commitment, and wanted me to extend our appreciation to the Office of Diversity, Equity, and Inclusion and the many individuals involved in hosting this event. We are truly honored to welcome Dr. Will Ross from Washington University School of Medicine to our campus this year. Our country is facing a time of tremendous opportunity for health equity in medical education and healthcare delivery, which I feel is reflected in the following quote from Reverend Dr. Martin Luther King. "We must accept finite disappointment, but never lose infinite hope." I hope and know for all of you that you will be informed and inspired by Dr. Ross's presentation this evening. Thank you.
Thank you very much, Dr. Zala. Now I have the honor of introducing our 2024 MLK Junior Health Equity Lecturer for today. Dr. Will Ross is the Associate Dean for Diversity and the Principal Officer for Community Partnerships and an Alumni Endowed Professor of Medicine in the Nephrology Division at Washington University School of Medicine. That's in St. Louis, not Washington State. A graduate of Yale University, he completed medical school at Washington University, and he did an internal medicine residency at Vanderbilt, and then did a nephrology fellowship at Washington University. I was just asking him, I said, "So you spent all your time at WashU, right?" And he's like, "Yeah." He went to Vanderbilt to be close to home because he grew up in Memphis. Over the past 2 decades, he has recruited and developed a diverse workforce of medical students, residents, and faculty while promoting health equity locally, nationally, and globally. He is a past member of the Center for Disease Control and Prevention's Health Disparities Committee, where he helped incorporate social determinants of health in the CDC promotions framework and Healthy People 2020. He has promoted health equity locally, nationally, and globally through collaborations with the CDC and public health officials in Ethiopia and Haiti. He serves as the chair of the AAMC Advancing Holistic Review Initiative, and he is a founding associate editor of the public health journal Frontiers in Public Health Education and Promotion. Dr. Ross is also a founding member of the Collegiate School of Medicine and Bioscience, a magnet health professionals high school in St. Louis. Dr. Ross previously served as the chief medical officer and director of ambulatory clinics for the St. Louis Regional Medical Center, the last public hospital in St. Louis. Please join me in welcoming Dr. Will Ross.
Thank you so much for that welcome. It's just my pleasure to be here in Vermont. The only unfortunate news I have is that I didn't get a chance to see moonlight in Vermont. And I don't know if I can stay, but I really was hoping I could see a moonlight in Vermont. I am impressed with the operations, with the deanship, with all the leaders I've had a chance to meet, but I really had a great time with the students. They are so inspiring. They really are focused. They really have that passion, that fire in the belly. And so you really knew what you were doing, Dr. Mary, when you were able to recruit them here. So it's my pleasure to really talk about a subject that's really near and dear to all our hearts, and that is the dilemma in this country. And I chose this topic because it incorporates 3 critical issues that we're facing. First, we do have a dilemma. And the dilemma is that we are more divided now than we've been in the past 150 years. I'm an optimist. I think we can navigate this path. I was telling someone earlier, I was reading the book by John Meacham, who really was commenting on how far America has come and how far they will go. So I'm an optimist. So we're going to talk about that dilemma. we're going to talk about equity and diversity. And I want to make sure that we leave her understanding that connection. It's a lot more complex than many people are willing to realize. And so I want to lend a philosophical slant to that, so we can all walk out here knowing what needs to be done, what are the skills, what are the areas we need to focus on to truly achieve equity. Now, I want to present something to you. It's not a hypothetical. I just want to reflect on this. I made this statement many years ago to our executive faculty at Washington University. And I said that, what is our purpose in medical school? And at the time, I had just finished reading Drew Gilpin Faust's letter at Harvard on the necessity of academics. So she asked that question, what is the really purpose of academics? Why are we here? What's our reason debt? And she commented that the sole purpose, the major purpose of academia really is to promote socialization, uplifting mankind. And so if we're not socialized to a concept, and if we're not lifting mankind, then what is the role of simply conducting great research or doing phenomenal public health work or doing great clinical work if you really aren't affecting the outcomes that we need to be doing? So let's make sure we don't have the disconnect. So I'm gonna ask you, as we think about what we're supposed to do in academia, are we there? And when we think about what's facing us in terms of the health disparities, what is our role? Should we engage in the amelioration of these widespread global health disparities? Is it under our purview? Do we have the resources to do that? So many people will say, well, that's too much. We have a tripartite mission, right? Clinical work, academic research, and teaching. And I've been really anxious to actually dismantle that construct and make it a quadripartite mission. I want to add in community health and community education. I think that really is what we're supposed to be doing in academic medicine. So I ask, is that a pipe dream to really talk about our true commitment to the community? Or are we simply espousing a position that we simply aren't able to execute because we either are under-resourced or we're simply overextended? I don't think that we are overextended. I don't think that we're under-resourced either. I feel so strongly about this because over years, over the 40 years or so I've been involved in this kind of a work, I still keep seeing the same data crop up. And that is the unconscionable disparities that persist in this country. I travel the world and I've seen disparities in certain zip codes in St. Louis that surpass that of certain third world countries. That shouldn't happen. This shouldn't happen. Certainly, we're looking at the life expectancy in years, race, ethnicity, in that time period, 2019, 2021. And you can see there was indeed a 2-year reduction in life expectancy, and that was primarily the COVID effect. But if you look at two groups here, the African Americans, you can see a 4-year reduction in life expectancy. As you can see, remarkable life expectancy decline in Asian Americans. The only group that really did not have a significant decline were the Asian group here. Okay, sorry, I couldn't read my, okay, yes, so the Asian group here. So again, this is unconscionable, but there's something that's even more sinister in the data. And this really is personal. And I have to give you a personal story. And that is, in this country, one of the wealthiest countries in the world, we still have this type of data. And over the past 3 years, we've actually seen an increase in the maternal mortality. Whether you stratify, when you stratify by race, white, Black, Hispanics, you still see the same phenomenon. My wife is a medical professional. She's highly trained, highly skilled, highly educated. And during our first pregnancy, she developed eclampsia, not preeclampsia. She actually had seizures and renal failure. And I'm in the hospital and they're saying, Dr. Ross, your wife has not made it in the urine. She has acute kidney injury. I'm a nephrologist. And I'm learning this. And I'm going in there and I'm thinking, oh my goodness, I'm going to lose my wife. And it's just, I couldn't really think about that. I had to do what I could to preserve my wife's life. Fortunately, she did well. We lost our child, but I maintained my wife. And I look at this data, I think how many women are experiencing this? This happens so much because of the cumulative allostatic load that's placed on women in this country, that cumulative stress that leads to this type of outcome, as well as the fact that we don't have the overall supportive care for women in this country. We provide prenatal care, a few months of postnatal care, but we don't provide that interconceptual care, if I may, really year-long care to really deliver the type of treatment, type of care we need. And thus, we have this type of mortality. For all those sitting here, this is unacceptable in this country, and something needs to be done urgently. Now, you can tell me, well, Will, you're in New Hampshire, and everybody's healthy in New Hampshire. You're the healthiest state in the country. So you have this wonderful healthcare plan. I think New Hampshire and Maryland, maybe Maryland has more of a global budget for health than New Hampshire. Someone here can clarify if that's true. Regardless, you have this phenomenal healthcare plan. Everyone does well. But when you actually look at Vermont and you dissect regions of the country based on the social vulnerability index, the social vulnerability index is a marker of the resilience of a community to overcome personal tragedies or stressors to their human health. And a high vulnerability index implies a range of factors that are actually arranged to suppress overall life expectancy and reduce their ability to reach their full health potential. So I decided to look at Vermont and look at that social vulnerability index. And in this map, I want to just show you about the coding here. The social vulnerability index is coded from 1 to 5, or 1 being the lowest, 5 being the highest. And here it's actually geocoded and color-coded, with the purple area being the highest social vulnerability index in purple, and the yellow being the lowest social vulnerability index. And if we look across the 4 domains of the SVI, unemployment, income, education, health insurance, and poverty, you'll see there is indeed a phenomenon here in New Hampshire, where the highest vulnerability indexes are here in the north part of your state. We're here, right? Looks pretty good. This is Burlington. This is a relatively well-educated community. But we have to ask, where are the resources deployed? Are they being deployed commensurate with the need? And if not, then how do we have this type of reallocation in order to improve this social vulnerability index? in this state. There's a lot to say here. And in this time period, when we're so divided, when we have so many complex issues facing us, it really is time to talk. It's not time to talk, it's time to yell. If we don't yell, then as Dr. King said, history will have to record the greatest tragedy of this period of social transition was not the vitriolic words and other violent actions of the bad people, but the appalling silence and indifference of the good people. We're the good people. We're the good people. We can't be quiet. We have to advocate. I was telling the students, we have to really, get loud. We have to really be bold in what we're saying. Now, this issue of really speaking out, speaking loud, being bold, was really important to me at a young age. I grew up in Memphis, Tennessee in the 60s. A lot of things happened in Memphis, Tennessee in the 60s, right? And I was right there. It unfolded in my eyes. I lived 15 blocks from the Lorraine Motel in Memphis. And I was old enough to really grasp what was happening. I was precocious. I asked lots of questions. And I heard the answers and I said, oh, why is this happening in this country? I saw the sanitation strike really affecting my community, and the reasons for the sanitation strike when two garbage workers were compressed by a garbage truck because they were not allowed to enter the building to escape the rain. It's just a horrible tragedy. Well, let me go back here. Well, I was in the right place at the right time. Had a difficult upbringing. I was raised by a single mother who had some mental health issues. I had 5 brothers and 6 sisters. There were 6 of us. And we were raised on government assistance in a tough neighborhood with gangs moving in. And I was a really frail guy then. I guess you're saying, well, nothing has changed, right? I was frailer and thinner then. And I was really susceptible to taunts and violence because I couldn't defend myself. So, but I was kind of a nerd. I guess you guys, who's the guy, Urkel? Yeah, I was Urkel. Oh my, I had the pants are high, the suspenders, and I walked around like this. I told them, the students when I was in college, I was so proud because I purchased a Texas Instrument SR 51-2 and I put it on my belt. And I could whip that bad boy out, that was who I was. And that looks great on the campus in New Haven. It didn't work out that well in the ghettos of Memphis. So I was a target. And my high school guidance teacher said, "Will, we have to get you out of here, and my husband can help you." Her husband happened to be Benjamin Hooks, who was the NAACP national director, who lived in Memphis and was really active in the civil rights. Close colleague of Dr. King. And they said, "We're going to get you out of here because we need you. We need you to do something." He introduced me to 2 people. Shirley Wexler, her husband, Alfred, had passed when I took this picture with her. And Jed Dreyfus, his wife, Jeannie, passed when I took this picture with them. I still stay in touch with them. And they said, "Okay, we're going to get you out of Memphis. And you have to read some books though. You have to read seriously some deep philosophy in order to understand what we're doing." You see, the civil rights movement wasn't a reactionary movement. It was a movement constructed by some of the deepest, some of most skilled scholars and thinkers in this country. I think a lot of people underestimate that skill. Angela Brown was a phenomenal scholar, is a phenomenal scholar, and um, I'm thinking in Los Angeles, Kwame Ture, it was at that time Stokely Carmichael. These people could sit in any institution, at this institution or anywhere else, and they will hold their own with some of the most intense, deep texts. They were scholars. And they were guided by this understanding of philosophy dating back for centuries. And they built that into the framework for the civil rights struggle. And Shirley Wexner and Jed Dreyfus wanted me to know that. They said, we got to first get you out of Memphis. And so they were really supportive. They said, we're gonna send you for a couple of summers to a small little school in New Hampshire, and we want you to really learn with those really cool students. So I was sent to Philip Sexer Academy, and I took physics and philosophy. Physics because it's such a geeky. I just love physics. That's why I'm a nephrologist, because nephrology is nothing but physics and math. So it appealed to me. They funded my whole time there. And when I went back to Memphis, they said, okay, where are you gonna go to school? I said, you know what? When I was there at Exeter, I took a physics exam and I scored a 50 percentile. And I cried because I said, they're gonna be disappointed in me after all the work. I said, I failed them. And then I went back to the room and I thought about that. I said, wait a minute, 50th percentile. That means that half of the class scored lower than the 50th percentile. I said, oh, I get it. So I was in the middle of the class. I'm coming from an inner city ghetto, a poor public health, poor public school, and I'm scoring in the middle of the class at one of the most elite schools in the country. Can you imagine what I could do if I had their resources, if I had their opportunities? You know, they went in, they vacationed in the Riviera. I vacationed in Helena, Arkansas. So they had some resources I didn't. I said, if I had what they had, I would blow them out of the water. And so I said, I'm gonna go back. I'm gonna really immerse myself in this work. I'm gonna ramp up my study skills, and I'm gonna show them that I can do this. It was a transformative moment in my life because any vestige of imposter syndrome was dismissed. My confidence level just accelerated, off the chart, still off the chart. Yeah, so I became really confident, and that was important because I felt I could do that, and I owed it to these people who devoted so much to the civil rights movement. We talked, and a part of our discussions, gosh, I was handed books by these philosophers, Thomas Hobbes, John Locke, Jean-Jacques Rousseau, and we talked about the social contract theory, the fact that ultimately we here, as I alluded to earlier when I quoted Drew Gilpin Faust, we're here to uplift the human condition. And if we're not doing that, then we have to ask, what is our purpose? So the social contract theory really appeals to me. And that led to this remarkable person, Reinhold Niebuhr, who appealed to me because Niebuhr was one of the most prominent theologians in the 20th century, and he really influenced Dr. King. In fact, if you go back and review most of Dr. King's writings, you'll see how much he really respected Reinhold Niebuhr. Reinhold Niebuhr's seminal thesis was entitled Moral Man and Immoral Society. He spoke on something critical. It was called moral valuations. And what he meant by moral evaluations is that we have a country which espouses these virtuous moral principles about life, liberty, and the pursuit of happiness. And every individual should have access to that. Every individual who's not Black or Native American should have access to that. So there is one moral level for one group, but then there's a different level for everyone else. And he called that out. He said, this is an abomination of what we really call morality. And America has to really look inward. Otherwise, we will devolve, or perhaps we had already devolved into an immoral society. This was followed by another landmark text. This is by a Swedish sociologist, Gunnar Myrdal, and it was entitled An American Dilemma, thus the title of my presentation to you, An American Dilemma. Gunnar Myrdal actually came to this country to really reflect on the status of life between African Americans and whites. He spent several years here, and he wrote this massive thesis, 1,500 pages. This is my original manuscript from high school. It's dog-eared, pretty torn, but I still consumed it. And I saw, gosh, he's so right. He stated that, that the conflict, he highlighted the conflict between our moral evaluations on various levels of consciousness and generality. That is, why should a country that espouses these principles actually not practice those principles with regards to the treatment of individuals who should be afforded the same rights and principles? He was not alone. Halfway across the world, there was another phenomenal person you should all know about, Bimral Ambedkar, who was actually one of the, who drafted the Indian Constitution. He was a leader of the Dalit, or the untouchables in India. And he basically espoused the same perspectives as Dr. King. He said, you can see the language, you can see the similarity in the language. He said, a just society is that society in which ascending sense of reverence and descending sense of contempt is dissolved into the creation of a compassionate society. He was not popular in India because he was promoting the untouchable class. And even Mahatma Gandhi refused to acknowledge Dr. Ambedkar as a prominent moral force in India. And we all know, about Dr. Gandhi's philosophies of morality and nonviolence. So even within remarkably enlightened people, we can still have these moral valuations. So this is important. I wanted to give you that philosophy discussion. It's really important because it really primed me for my position when I returned to Washington University in 1996. I had been director of a public hospital, which closed after a certain period of time because it ran out of money. I was telling the students, you have to have confidence to be able to call out an injustice when you see it. And I called out the injustice that certain people in St. Louis weren't providing the funds for this hospital when they should, and these people should be held accountable. And the person I said that about was the first African-American mayor of St. Louis. He didn't like that at all. And he called me to his office. He said, "You're gonna have to retract this." I said, "Nope, not gonna happen." So I was, let's say I was eased out of my position there. I was still a WashU faculty, but I was eased out. I was transitioned out because I called out the Black mayor of a predominantly Black city. First Black mayor. That took guts, okay? That took gumption. But it was the right thing to do, students. It was the right thing to do. You call it out when you see it. And you don't worry about the repercussions if you really feel strongly about that. Those are the values that we should hold dear. So I called it out. And I was, when I went back to Washington University, to this position that I'm in right now, the dean said, well, Will, I want you to continue a program to recruit Black students, and you can still do your research and your practice and all that. And I said, well, I'm not gonna just do that. I said, we have to transform what we're doing. And I said that I don't want to be in an office, with no disrespect to people who do diversity work. I don't want to be in an office just doing diversity work. Because I'm gonna be really candid with you all. Over the past 20 years, diversity and inclusion has become a cottage industry. A cottage industry of people who really believe this work, who are devoted to this work for the right reasons, the reasons that I'm devoted to this work. But they're focusing exclusively on that work. And sometimes they have to step back and ask, wait, why am I here? What is my raison d'etre? Why am I doing this work in diversity and inclusion? What am I trying to achieve? And I have been concerned over many years that those in diversity and inclusion are gonna find themselves in between a rock and a hard place, because I envision that this country at some point would not fully support diversity and inclusion. I imagine 25 years before the recent affirmative action case that was going to happen. I was absolutely sure that it was going to happen. Did you know why? Because Senator Day O'Connor said it was going to happen. She said 25 years from now, this is going to happen. So I have to believe her. I did believe her. So I started thinking about how do I reconfigure my office to really do the things that we're supposed to do. And then how do I go across the country and talk to diversity officers and tell them you should do the same thing? Well, let me tell you, here's what diversity is supposed to do. First of all, remember that diversity is not an outcome, okay? Diversity is not an outcome. The outcome is inclusive excellence and equity. In our sphere is health equity. That's what we're trying to do. And we cannot lose track of that. The outcome is not just having a group of students or diverse faculty, that's all good, but what are they gonna do? Diversity asks us, first of all, to realize our values. What do we stand for? What are we trying to achieve? What are our core beliefs? You have to interrogate those core beliefs and ask, okay, these are my beliefs. Now, how do I support these beliefs? How do I elevate these beliefs so they translate into uplifting of human mankind? You have to first realize your values. Then you have to address the complex problems in our country. They're myriad, aren't they? You have to address these problems. When you actually get a diverse group of people in a class, they outperform a non-diverse group, whether they're in business, law, or medicine. A diverse group will always outperform a non-diverse group. I mean, that's data that's been promoted for years by Harvard Law School, McKinsey and Associates, abundant data to show that. And so what are the complex problems? We were talking about those complex problems, the problems of resource reallocation, problems of denigration of humans, the dehumanization of certain groups, the problems of overcapitalization of America, of society. These are complex problems. You need a diverse group to address those problems. Then when you do that, that diverse group will actually enhance our viability. We will become, the society will recognize that, wow, these people are real, they're sincere. They're doing what they're doing the right things. They are practicing what they preach. Therefore, we believe them, we validate them. They're the right group to do this. And as a consequence, our stock increases and our acceptance increases and our respect increases. That's what diversity is supposed to do, right? Let's talk about these values. What are your values? What are my values? Well, my values, as I said earlier, it stems from my growing up in Memphis, Tennessee. But during the 60s, things were happening across the country, particularly this image from the Watts riots in 1965. 1965, a Black man was arrested for driving erroneously, and he was assaulted. And the Black community said, you know, enough of this. And it was a straw that broke the camel's back, and they disrupted. You know, Langston Hughes asked the question, what happens when our dream is deferred? Does it sag like a heavy load, or does it explode? Well, Los Angeles just exploded because of these dreams deferred over so many years, if not decades. And President Johnson at the time, seeing this, dispatched Governor Otto Kerner he was former Ohio governor, he dispatched him to assess what really is happening in Los Angeles, what's happening in our country. And Otto Kerner charged a group of a Blue Ribbon task force to really look at the events in LA. And they concluded, and you all heard this before, that our nation is moving toward two societies, one Black, one white, separate and unequal. That was in 1968. It's more complex than that. I think the truth was in this report. This is by Chris Mary, who is a director of the Harvard Global Public Health Institute, who conducted a series of evaluations of life expectancy in different parts of the country. And he concluded, no, there aren't two Americas, there are 8 Americas, stratified by race, ethnicity. And so you can see on this map of males and females, the life expectancy from 60 to 80 years. And in this map, you can see that, let's look at the difference between the lower panel, which are Black, high-risk urban individuals, and the upper line, which represents Asians. And you can see a kind of a spread here. This disparity, this difference, this has not changed in the past, well, gosh, I was going to say 20 years, but hasn't changed since we actually started collecting the data. And these 8 Americas reside in the country that sometimes doesn't really recognize this distinction. And we treat Americans as if, well, everybody, we all American apple pie. We all believe this about our society. We elevate the free market. We're very much capitalist. We're all these beliefs are reasonable beliefs, but we shouldn't assume that everyone harbors those beliefs. And if someone doesn't harbor that belief, we shouldn't be critical and say you're un-American because you don't harbor these beliefs about life, liberty, and pursuit of happiness. This is what happens when we recognize that there are 8 distinct groups. We're now in the age of widespread immigration, which is good for America because our group just founded on immigration. And now we're seeing even more differences in life expectancy as new groups coming in, unable to access resources and finding themselves faced with their hierarchy of needs, their Maslow's needs, left without ability to access care, and their overall health declines also. Now, this all happens despite the fact that last year, I shouldn't say last year, I have the data from 2022. America in 2022 spent $4.5 trillion on healthcare. It's 18% of our gross domestic product, 14.5 trillion. And so you can see the growth in our healthcare expenditure over time. And you can see how that relates to life expectancy. But I'm sorry this graph didn't really display well. But at the top of this graph, you can see other countries that actually have a higher life expectancy despite a lower healthcare expenditure. So we're spending this money, but the outcomes aren't there. And we should start asking why. Well, I asked why. When I went to the office in 1996, after the dean asked me to restore this office, I said, no, I can't do that, because I think there's something larger that we have to be doing. Those of us who were initially minority affairs officers. I said, no, we have to expand our horizons. We have to expand our thinking. We have to expand our philosophy of why we're here. And that means that we have to change what we're doing. Insanity is doing the same thing over and over and expecting a different outcome. And so I was invited to give a talk. I'm laughing. It's kind of, it was amusing post facto. I was invited to give a talk to WMC in 2004 on, and you can see the topic of my talk at that time, the changing roles of minority affairs officers and new direction towards health equity. And I said, it's time to change. You can no longer sit in your office and care for students in isolation. You have to care for students, but you have to step outside and you have to ask, who are the support staff for students? And what about the support for residents and fellows and faculty? You have to embrace that. And then you have to go even further and you have to say, well, what is the purpose of diversity, right? Is to is to realize our values and address these complex questions. You have to address those complex questions. You have to step out and start talking about health equity. You have to start looking for political solutions to these long-standing health inequalities. And they said, Will, please, we don't have time to do that. And I said, you don't have time to not do that, because you will be pushed to the periphery because the nation is changing and what you're doing is no longer going to be viable. Well, they weren't happy with me during that time. Let's see. Okay, here's the response I got from the audience. Okay, the left-hand panel is the storming of the Bastille. There he is. He's up there. And right-hand panel, the mob after the Frankenstein monster. Get him. I'm really afraid of this guy here. He looks really demonic. I'm glad this guy wasn't coming after me. So they were unhappy. They weren't, it wasn't in jest. They were unhappy. They were angry because I was advocating that they assume a greater role. They may not have had the commensurate increase in funding, but I'm asking them to do more with less. It doesn't seem fair, does it? Life's not fair. We're in this position of authority. We have to do more. I grew up in the civil rights movement, remember? I saw them do a whole lot more with a whole lot less. I said it's important, it's imperative that we do this, that we create within university Vermont, within WashU, within all these other places, it's a medical center without walls. We have to expand our offices to really incorporate community and population health. And we can link our diversity of our workforce with this improved health outcomes, right? That is the purpose of diversity, right? We have to resolve our intractable disparities. That means we have to link our mission of research, clinical practice with achieving health outcomes. We can't sit back and really be accepting of the fact that our medical research takes 15 years to enter a clinical, to improve clinical outcomes, to enter the market and actually improve clinical outcomes. 15 years is unacceptable. When we have those disparities that I share, when we have that maternal mortality that I shared, or even infant mortality, we have infant death rates in certain parts of the country and in healthy New Hampshire of about 15 deaths per 1,000 live born, with the World Health Organization benchmark being 5 deaths per 1,000 live born. In certain zip codes in St. Louis, we have infant death rates that approximate 20 deaths per 1,000 live born. I've been to many countries, and I've not seen death rates that high in some of the poorest countries. This should move us to action. This should be unacceptable to all of us. You know, I thought I had some friends. And so I started, after I made that presentation, I started getting a lot of negative fan mail. And this one I found really amusing. This was addressed to the Associate Dean for Adversity. And they gave me pause. They gave me pause. I said, is that real? Is this a joke? I never know. I never was able to corroborate that. All I was saying is that maybe I'm not as articulate as Ta-Nehisi Coates, who wrote a great book, Between the World and Me. And Ta-Nehisi Coates said that one could not at once claim to be superhuman and then plead mortal error. I propose to take our countrymen's claims of American exceptionalism seriously, which is to say, I propose subjecting our country to the exceptional moral standard, a moral standard. He called it out. We should all call it out. So this moral standard, this exceptionalism that Ta-Nehisi Coates is talking about really relates to our claim that we're this wonderful, wonderful country, spending $4.5 trillion in healthcare, and yet we can't improve the lives of our loving mothers and women in this country. This report came out, the Unequal Treatment Report. I think many of us are aware of this, in 2002. And when this was released by the Institute of Medicine, Alan Nelson was president of the Institute of Medicine. And I was there when they presented this work at the New York Press Club. And Alan Nelson was emphatic. He was banging on the lectern. He said, okay, stop with the data. I'm sick of the data. We know what the data shows. It hasn't changed. It hasn't changed. It's time for action. The goal of this report was not just simply to disseminate the data. It was to say, this is a finality, okay? We know it exists. Move on, right? That was the purpose of the Unequal Treatment Report. And so I decided to move on. I thought he was right. I said, okay, let's think about how we're constructing these offices of diversity and inclusion. If indeed we need to realize our values and address these complex issues. So I said, we need to just fundamentally change our offices. And this is a report from a strategic plan I did in 1996. I said, okay, let's place moral principles here at the base. This is our foundation. And that our aspiration is health equity. And then what are the pillars that we need? We need to address workforce diversity, program development. Program development means that we have to have structures in place to support this workforce diversity. We need to have community engagement. We cannot do this work unless we're engaged in the community. I had some great conversations with everyone this morning about community engagement. And that has a segue into population health. You know, you cannot do those things and claim that you really are trying to promote diversity. You just can't take one of those pillars and say, we're doing diversity. You won't be doing diversity. You'll be accumulating bodies, but you won't be doing the true work. So I'm going to get even more controversial here, if you don't mind. So when I was putting that report together, I wrote a paper. And in this paper, this was really a tough statement to make. Now, I don't think a lot of people understood this. I said I emphasized workforce diversity first, because I said the American educational system has failed to prepare students of color to meet the standards for medical school admission. Wow, that's a loaded statement. That's really loaded. What am I saying? I think you know what I'm saying. Yes, we need to actually have more students in medical schools of color. We need to have more residents, we need to have more faculty. But what we've done over the past 40 years is that we've taken the few students that are here and we've been engaging in this shell game. We're taking one from here, one student from that program, one student from this program, and we have not elevated the actual number of medical students in the country. The number of medical students in US medical schools have been flat since 1980, flat since 1980. In fact, in 2014, Mark Neve, who was at the WMC, their diversity officer, published a report stating that in 2014, there were fewer Black men in medical schools than there were in 1980. The numbers are flat. Most recent report from the WMC showed a modest increase, 0.3% increase in Black women, 0.1% increase in Black men. Hispanic men and women were about 2% increases. Those are marginal at best. And so we just can't accept that. We can't do this game, this shell game. Society is not benefiting from this, right? We have a complex problem in the society. We have these unacceptable disparities, and we just simply can't say, let's take this school from, Stanford, I'm head WashU was saying, let's take the school from Stanford, and Stanford students said, let's take the student from WashU, and the actual number of students in our schools in the pipeline doesn't change. I can't, that's unacceptable. And I said, something has to be done about that. And so I said, we can't just talk about these things. We have to get real. I said, who am I? These are large issues. These are macro issues. Society needs to change. But you know, we can do things even while we're waiting for society to change. Society changes like the Titanic. It changes it doesn't change on a dime, right? So I said, I'm tired of waiting. You know what, if we need more students of color to enter biomedical sciences and clinical medicine, I'm gonna create a school. And I went to the dean, I said, I'm gonna create a school, a high school in St. Louis for students who wanted to, of color who wanted to, it wasn't students of color, students who were disadvantaged. I had whites and Blacks and Latinos and Muslim students there. Said students who espouse to careers in medicine and biosciences. It's gonna be a public school. He said, don't do it, Will, don't do it. Washington University cannot put their name on this. We don't want our imprimatur on a program which could fail. So I went back to the superintendent of the schools. He said, what does the dean want to do? I said, let's do it. And we did it. That was bold. I lost one job. I was about to lose a second. So, but it didn't matter because you have to do the right thing and you can sleep well knowing you're doing the right thing. So we created this school, the Collegiate School of Medicine and Bioscience. We brought in kids who were like I was. They were throwaway kids. We said, you know what? We believe in you. We're going to give you opportunity and we're going to hold these standards. And we know that you won't just meet those standards. You're going to exceed those standards. We know that. We're absolutely convinced you're going to do this. And you know what? 95% graduation rates from these students. Here's a group of 5 of those students accepted Washington University in 2018. They went on to the top schools in the country. After 10 years, our school was ranked #2 in the state of Missouri. And so the detractors kind of fell to the wayside after that. They love the school now. But you have to believe in yourself. You have to know why you're doing this. What is the purpose of diversity? You can't just end there, okay? You remember the pillars. Okay, I'm talking about community engagement and population health. You just can't quit with just simply having the students. You have to create linkages to the community, which is why we created the Regional Health Commission to really integrate our federal qualified health centers and actually create programs for our students to really learn about integrated health care. And then we created an Institute for Public Health where we can actually address population health, address our research that's dedicated to population health. But it couldn't do there. We couldn't end there. We have to realize how complex issues in this problem means that we need to have a long discussion about equity. We have to understand what is equity and why that's important. This is 2020 Healthy People 2020 report. I was doing some work with the CDC, and it took about 3 years to have equity codified in this document. Just that word. It was controversial to use the word equity, and it took years to get a report that even used the word achieve health equity. We were all smiling because we were really happy that we actually got this done, but it shouldn't have taken that long. No, I was telling the students, you have to, if you want to do this work, you have to go all the way. And if you really want to affect change in this country, you do so through policy at the highest level. You have to be there at the table. So I was told if you're not at the table, you'll be on the plate. So I said, I'm going to get in the table. You know what I said to you guys this morning? I quoted Miseducation of the Negro, Carter Woodson. Carter Woodson said, you know what? If you want to get into the door, if you want to get into the room, you knock on the front door. If it's closed, you go to the back door. If the back door is closed, you go to the window. And if the window's closed, you break it. You get in the house. You know, Lynn Miranda said, you want to be in the room where it happens, right? So you want to be in that room. You get yourself in that room. You belong in that room. And so I heard about this task force meeting in the White House and said, I want to be in that room. I have something to say. I said, okay, fine, we'll get you there. This is kind of humorous. So I went in this room, and I was really having this great discussion at the White House about health equity. There's all these smart people around. They said, okay, Dr. Ross, you're here. This is a round robin. We're going to give everybody 2 minutes to talk about what they think are the most pressing issues facing the country. They came to me and says, okay, go. I said, what do you mean 2 minutes? They said, that would be a minute and 50 seconds. I said, oh, are you serious? A minute and 40 seconds? I said, okay. 2 things. We have to promote neighborhood revitalization. We need to create jobs in our communities. Number 2, we have to start focusing on funding for public health education. And we have to focus on maternal child health. Gosh, I got it out. I had like 10 seconds to spare. And then we had this great discussion. But boy, when you really put on the hot seat, you just have to say, here's what I feel in my gut. I'm going to say that. So we got that out. And we had changes in this country with the creation of enterprise zones, opportunity zones for those who are involved in neighborhood revitalization. It changed because we had a increase in funding for maternal child health through CMS. A lot of things did happen. I couldn't just quit there. I had to believe that it can't end with just changing the policies. We have to ask where are we delivering care? If we really want to affect change, then we have to ask, where do people receive that care? Where do we need to go? And here's another seminal report that's also about 1,000 pages, the 1995 Rand Corporation report. So I distilled those 1,000 pages into a few lines. Here's what it said. Okay, here's the summary. Healthcare is best delivered in community-based settings by culturally sensitive and ethically concordant providers. I mean, that's a powerful statement in the Rand report, which means that you can't just have a place, a hospital in Burlington, Vermont, and say, okay, everybody come in here. It doesn't work that way. You have to go into the communities. You have to go where they are if you really want to make a difference. You know, so I just was trying to expound upon that in the new journal we started. So are you with me so far? Because this all connects. Everything connects. It connects with what we're doing in diversity right now. Connects with what we're seeing in the community. That community is in here, in northern New Hampshire, and that community is in South Memphis, in Tennessee. We have those same elements. It all connects. And so this is a framework that was published by Yerby in 2020, trying to really show this connection of policy work with the social and structural determinants of health. Because we all know the social and structural determinants of health. Everyone can list those things. So the framework really talks about the best way of addressing those. And the most effective way is through political process, healthcare law. You have to change statutes. You have to change budgetary decisions. You have to change regulation and enforcement once you acknowledge the existence of structural discrimination, racism, sexism, ableism, and classism. You go to the policies. You have to walk the corridors where those policies are being discussed and where laws are passed. And then you apply those policies to all the systems that are operative in perpetuating these unfortunate health disparities. Disparities in public health, disparities in our neighborhood, disparities in education, disparities in economic stability. And then ultimately, these will all converge, and you'll then understand how we can create a country that has everyone living to their full health potential, which is what we're trying to do. That word is equity. For many years, I used the word health disparities to talk about this work. Disparities for students, the disproportionate burden of disease borne by a population, even when you control for access to care, those are disparities. I was giving a talk in London, and I was chastised. They said, stop using that word disparities. You need to talk about equity. Disparities is a zero-sum game. If someone's disproportionate burden and they need a reallocation of resources, then when you reallocate those resources, then someone's going to improve and someone's going to have fewer resources. So why do you have to play that game? Why can't you say that everyone should be able to be elevated to their full health potential? Why can't you make that statement? That's equity. Moving everyone to their full, so they can reach their full health potential. So let me conclude by looking at a summary. I showed you this initial conceptual framework, which had 4 towers, 4 pillars. I've since changed that framework. I think this makes more sense as we look about a health equity construct for academic medicine. It has the same basic components, and at the center is health equity. And then we have all these issues. We have to create a diverse workforce. We have to have community engagement and population health. Those are obviously along the same lines. We have to improve our cultural climate, and we have to have curricular design and support for that. And the reason this makes more sense to me is because I can see the relationship, and it's interdependent. And we can't address one. We have to address them all. In fact, simultaneously, we have to address these issues. The Supreme Court came out. We know what happened. We know what we must do. Dr. Muir and I, we understand that. We're working hard on some things. But here's what I say we should do. We have to remember when we're doing this hard work, what is our prime motivation? Our prime motivation is to uplift the human condition, which means we have to ask, who are we here to serve, and who is a population that's best positioned to serve the individuals there? I mean, are we here to serve her, him, him? We're here to serve all of these people. They all deserve to be treated with respect and dignity. They all need to be able to reach their full health potential. So I conclude that we spend a lot of time talking about diversity and equity. And I think we need to step back and ask, what are we really trying to do? Who are we trying to serve? And sometimes the best answers aren't what we have now with all our fancy discussions and ruminations and reflections. Maybe the best answers come from those who discussed this in the past. This is a quote from Francis Peabody, who was one of the deans at Harvard. It's called "The Care of the Patient." It's a powerful statement. And I think it really embodies what I'm trying to convey to you. If there's anything to remember, this is what I'm trying to convey. He said, "The good physician knows his patients through and through, and his knowledge is bought dearly. Time, sympathy, and understanding must be lavishly dispensed, but the reward is found in that personal bond which forms the greatest satisfaction of the practice of medicine." He said, "One of the essential qualities of the clinician is interest in humanity, for the secret of care for the patient is caring for the patient." Simple, plain. If you care for the patient, like that patient is your mother, grandmother, aunt, uncle, sister, brother. If you care for that patient, you're going to go all out and do what's necessary. You won't accept anything second level. You said, "No, I demand that this person receive the highest level of care." You should have that care, that feeling for any individual. That's simply the care of the patient. Let's take our fancy work, all our textbooks, all our graphics, all our student portals on compassionate care, and let's just make it simple. Let's care for the patient, period. I think that will solve a lot of issues. I was talking to said this important slide, the slide I was going to leave. I don't know if someone I said this is going to be my final slide. I can't remember who I said that to. Oh, okay, right, okay. Okay, so this is it. This is what I've been saying. And I submit to you that if we really are to take diversity, truly operationalize what we mean by diversity, it really fundamentally means that, hey, folks, let's care for the patients the way we would care for any patient. I hope this is really in line with what you've been thinking about in terms of the essence of Dr. King and what we should be doing as an academic medical center. I'm proud to be here to speak to you about this mission. And I hope that you also are inspired to make fundamental changes in what we're doing and take things that you have considered to be literally things that are fundamentally unchanged, fundamentally not challenging, not challengeable, rather, sorry. I hope that you can challenge these things. So please leave here with the sense of challenging all these dogmas that we've been supporting for so many years. Thank you so much.
Thank you so much, Dr. Ross. Thank you so much, Dr. Ross. This was very, very, I think it was challenging and also inspiring. I was taking it personally as a physician, and I was like, that is so true. Diversity is not outcomes. It's not bodies. It's what are we doing? Why are we here? Why are we doing what we're doing? And I think that's so, so crucial, and is a great reminder for us, for all of us here, no matter what we're doing. So I'd like to take this time to open it up for questions online and in the room here for Dr. Ross. Any questions? Yes. We'll get you the mic, okay, so that our online folks can hear.
It was really a wonderful talk and very thought provoking, and I'm intrigued by the model on that next to last slide that you had on the 5 points and trying to move them all forward simultaneously. And I'm just a sort of a person who tries to put things into action. It's a really daunting thing to be pushing 5 buttons at the same time. And I'm wondering if you know of any examples where you could choose 2 of those buttons and really push them hard while simultaneously opening the door for the others. Is there a draft effect? Can those others pull behind?
Oh, sure. Let's go back to that model. And this is the model you're referring to, or was it the prior model? This one. Okay. So so the goal of academic medicine is to uplift the human condition. And you uplift that human condition by paying attention to the health of a community. And if you truly enter a community and say, I want to make this community healthier, okay, I'm gonna bring a workforce there. I'm gonna bring people there who understand health, who understand healing. And I'm gonna put those people in this environment, and they're gonna heal the community. That's first and second. So that's the answer to your question. I've traveled around, I've gone in, medical missions, in places, really disparate, tough places. And they were always screaming, we need more personnel. We need some more staff here. I said, what we need to do is deal with the dilemma in front of us. We have people here, we have sick people who are forming lines, half a mile. Let's take one patient at a time and let's try to heal that patient. All these other things will follow suit. So that's that drafting construct that you use so well. Thanks.
Hi, Dr. Ross. Thank you for that illuminating talk. There are a number of things that I'm curious about and want to ask more about, but essentially, I'm curious about the ending of the story of when you started the high school and you said that the dean was like, nope, not into it, and you went and did it anyways. I would love to hear how that unfolded. And part B of that question is the high school now directly connected to the School of Medicine, and what does that relationship look like?
Sure. I went against the dean's wishes. I started the school. The dean didn't call me at all for several months. We used to meet on a weekly basis. Got no calls, nothing, radio silence. I said, it's okay. And then about 2 years later, he called me to his office. He said, Will, I see your school is doing well. He said, your school. How can I help? 2 years later. And so I said, we need some resources. He said, okay. So we, created these summer programs, research programs, internships at Barnes-Jewish Hospital, and just tremendous support. So it was belated, but it came through. Well, the second question?
Well, I think you answered it. Just essentially, it's wondering about what the relationship looks like now.
Oh, yeah, we have a formal memorandum of understanding between Washington University and the school. Full support.
Tiffany, see any online questions?
Also related to the, Sarah, oh, thank you. It's related to the school. It's remarkable how you created a school. My question is, how much support / buy-in did you have from partners and leadership when you were in the planning phase? If our state seeks to make change, we need two things: like-minded individuals and an in value of people to support the mission. These are the two challenges in our state. Thank you for everything you are and what you've presented.
Thank you. There was very little support at the inception, very little. I had no one in the room from Washington University or Barnes-Jewish Hospital. I had a couple of philanthropists, which always helps. I had some some people I knew who said, well, we believe in this, we're going to support you financially. That brought Washington University and BJC into the room later. So that helped. And I had some community activists who really believed in this, who said, this is what this community needs. We're going to work as hard as we can to make this successful. I had some hardworking people. I had some people who were willing to fund this. And I said, that's all I need. Everything else will follow. And everything else followed. And those community activists and those philanthropists are still on the board after all these years.
Thank you so much, Dr. Ross. We've spoken quite a bit about education as it relates here, and you presented on educational foundations for folks entering the field of medicine. As we think about sort of broader educational attainment as a social determinant of health, I'm curious how you see academic equity or educational equity as it relates to this framework. And is there a role that we as healthcare providers can or should be playing to advocate just as much for equity in public education?
Yes, we should. We should. Missouri is a country that's is a state rather that's relatively sparse in their allocation for public education. In fact, one of the worst in the country. And so we don't, and you get what you pay for. I was looking at the per pupil expenditure for public education in New Hampshire. It must be 5-6-fold greater than Missouri. I was shocked. It was really a significant improvement. And yes, look at the outcomes in New Hampshire. And so this is an ongoing battle. These are the issues that are the hard issues, because it means really talking to policymakers, talking to legislators about, okay, we need adequate funding for public education in New Hampshire, because New Hampshire is not monomorphic. It's not just one, nebulous state. There are different, there are heterogeneous zones in New Hampshire. And as a consequence, there are heterogeneous needs in New Hampshire. So what may be adequate for, I don't know what this county is, may differ radically from what is adequate in the northern part of New Hampshire or the northeast part of New Hampshire. And so we have to start thinking about funding that's appropriate to need. And that's almost, maybe contrary to what people will say. Oh, no, just give us this global funding and we're going to make it equitable. Everyone gets the same share. Everyone gets the same share. That's not equity. That's not how the term, that's not the purpose of that term when we say equity. And so it means saying, well, you know what, there's a greater need here, and we should help make sure the allocation is commensurate with the need. It's a hard sell, isn't it? It's really hard, even for a state like New Hampshire. It's a hard sell.
It's better in Vermont.
Oh, what is it? Did I say New Hampshire? Okay, I do apologize. I said New Hampshire, I meant Vermont. Oh, God, okay. You're gonna throw me out.
Got you. We got you. We got
We're
you.
used to
I'm
it.
totally with you. I'm totally with you.
Okay,
We got you.
okay.
There's one more.
Forgive me, please.
Dr. Ross, there's another question from online.
Yeah, we have one more question. So this is, how did you address the climate in the school for the students of color and for the faculty that you brought in to the high school?
The high school?
Mhm.
So when you say the climate at the high school,
Yeah. I think that that's what the question
I will make
means.
sure I'm trying to understand the question. So you're talking about the academic climate or the cultural climate?
The cultural and overall climate.
Okay. Well, frankly, the students got along. You have to realize that, a lot of these students were low-income whites. A lot of these students were low-income blacks. And we always make we make this distinction, just like we make the distinction between urban whites and urban blacks, or rural whites and rural whites. A recent report looked at the distinction, and there's a lot more common between the rural community than the urban community than we want to acknowledge. These are not disparate societies, disparate groups of people. They are really, we knew that was the case during the opioid pandemic, which devastated rural communities. And then it turned around and devastated urban communities, and it devastated rural communities for the same reasons. So frankly, it was a magnet school drawing students from across the region, and they came in and they looked around, and it was like a United Nations. I mean, it really looked like the United Nations. And they said, we're all here. This is really cool. It was a wonderful, wonderful climate. We're the most diverse school in the state of Missouri. I almost said Kansas.
Well, I want us to please give a round of applause to Dr. Willigan. This was Dr. Ross.
Thank you.
Yeah, this has been stimulating. I mean, it's gonna help me as I go through every day what I do clinically and in the realm of DEI. I would like to thank all our audience for online and in person for attending, and I hope you have a great evening. Thank you all.